So like I was saying, we're going to be discussing evidence-based physical diagnosis. And of course, my passion is endocrinology. So today we're going to have time to go over thyroid disorders. And I hope in the entirety of this lecture, if you have any questions, you may stop me, post them in the chat. Feel free to interrupt at any point, right? So the two aims for this lecture, like I said, we're going to be discussing the importance of the evidence-based physical diagnosis. And then we're going to apply some concepts of clinical epidemiology that we have been reviewing. Oh, this is a new gadget that I have to remove. Much better. Thank you. I'm going to get rid of this. Okay. The new concepts of clinical epidemiology that we have been reviewing in our last EBM sessions to the assessment, in this case, of endocrinopathies. Right? And as you know, I like to use this format in Prezi. So if you want to find anything, it's all available online if you Google my name. All right. So one thing that I always find important to know is that up to 80% of our patients that have a goiter are actually clinically euthyroid. Only 10% of these patients will be hyperthyroid, and 10% of them will actually be hypothyroid, contrary to sometimes what we may think, that they all have a hyperactivity of their thyroid function. Now, there are two important landmarks that we have to keep in mind. And these two structures are in the midline of our necks. The first one is the laryngeal prominence of the thyroid cartilage. We have the name right here, and there's a little graph here as reference. And it's the V at the top of the thyroid cartilage. And actually, the thyroid gland does not, as you can see in the picture, lie on top of that, despite its name. The second landmark or structure is the cricoid cartilage. Now, each lateral lobe of the thyroid is about 4 to 5 centimeters long, and it's holding or hugging the trachea tightly. We know that the isthmus is just below this cricoid cartilage right here. And these two landmarks will help us locate our thyroids in a patient's neck. Now, I use a caution sign here because if this laryngeal prominence, this V that we were referring to before, is a little lower in the neck and closer to the suprasternal notch, and by that I mean less than 5 centimeters away from it, then our patient has what we call a low-lying thyroid. And this is something that will often be kind of hidden behind the sternocleidomastoid muscles and the clavicle. So it makes it almost impossible for us to palpate, even if there's a goiter or an enlarged thyroid gland there. And why is this important? Because this is actually pretty common in elderly patients. So we have to keep, the low thyroid or low-lying thyroid in mind. Now, I want to give you some tips as to how to palpate the thyroid gland. But before this, let me show you a very good video from Stanford Medicine. All right, let's move closer to our mark. Here we go.
I'm now going to demonstrate the
I don't know why the subtitles are in Russian.
is knowing the anatomy.
The
So
Greek.
follow along with me and put your finger on the tip of your chin, on the mentalis muscle, and then slide your finger down the midline. The first hard structure you hit will be the thyroid cartilage, or the Adam's apple. You're actually going over the hyoid bone, but you generally don't feel it very clearly in the midline. So the first thing you hit is the top of the thyroid cartilage. Slide your finger down the edge of the thyroid cartilage like the prow of a ship, and you will next hit the cricoid cartilage, and this is the cricothyroid membrane. And then below the cricoid cartilage will be the first 2 rings of the trachea. It's important to know this anatomy because the thyroid gland does not really lie anywhere near the thyroid cartilage despite the name. The exam is best done by getting behind the patient and once again using my anatomy, finding the thyroid cartilage, the cricoid cartilage, the first 2 rings of the trachea. I then put my fingers in the midline over the first 2 rings of the trachea. That's where the isthmus of the thyroid lies. I then flatten my fingers. It's almost as though I'm trying to choke the patient. And I slide my finger slightly to the side. And now I ask the patient to swallow. And I'm concentrating on whether one set of fingers went up disproportionately compared to the other. Once I've done that a couple of times, I can then push the thyroid gland over with one hand and palpate the lobes with the other hand, and then do the same thing this way. Don't forget while you're at it to do a complete lymph node exam, and also to look at the hand to see if it's sweaty and if there is a fine tremor.
All right, so as you can see, there are different ways to do this. Now, the first thing that you notice is that we should probably have our patients just sitting upright and looking straight forward. Now, as we mentioned, the neck landmarks are important to know where to locate, and that's the first thing that we need to palpate, no matter how confident you are that you can find the thyroid gland just by looking at it or just by experience, because we can be fooled into believing it's something that is not really there. We'll talk about that later. Now, there are different techniques depending on what you prefer, what your patient's preference may be. If you're going to use an interior approach, you could do it in two different ways, right? The first thing is always to locate your thyroid bed. And once you locate your thyroid bed, you can use two hands. I'm going to use my thermos right here. So you can use two hands and you can use your thumbs, one at each side of the midline of the neck. Now, if you're still coming from the interior approach and you're facing your patient, the second way to do it is just to use one hand. So you place one thumb at one side, and then you place your index and middle finger from the other side. And that way, you're pressing both lateral lobes. You can also use a posterior approach, in which you'd be using the same fingers as the last. Your index and your middle finger would come midline. This is your patient, and you're coming from the back. And then with those fingers, and you're pushing on each side. Now, once your fingers, depending on whatever approach you want to use, once your fingers are there, you may ask your patient to swallow. And this is usually helpful to see the thyroid, like you saw in the video, move up and down. And this will help you differentiate from other structures. That's why when you're evaluating a patient, whether it's in an endocrinology practice or your primary care, or in the primary care setting, you may have a little sip of water next to them just to help them with the motion of swallowing. Now, if a goiter or if there's a nodule that's unilateral, it's helpful to ask the patient to turn their heads, and that will allow for a better examination. Let's say if I ask my patient to turn to the right, you will be better examining the left lobe and vice versa. And you can try this yourselves just to orient in space. If there's a significant goiter, it's important to listen to the thyroid gland as well to see if there's a fluid present. Now, we're talking about goiter, but what should we be calling a goiter? The revised WHO definition has 3 different grades. Grade 0 is something that is a thyroid gland that's neither palpable or visible. Grade 1 is something, or a goiter that's palpable, but that you can't really see with the head in the normal position. And grade 2 is a goiter that you can clearly see when the neck is in that normal position. There's something that we call the rule of thumb, right? This will state that if the lateral lobe is larger than the distal phalanx of your patient's thumb, then it means it's enlarged. Now, and this is just how the neck contour and like how goiters may look. There is an interesting but rare sign that I remember from medical school. There are some large goiters that may actually extend all the way to the superior mediastinum. When they do that, they pass through a very inflexible structure that we call the thoracic inlet. And this is just sort of a bony ring that's composed. And if you can think about this here, just by looking at the image, that's composed of the upper sternum, the first rib, and actually the first thoracic vertebral body. Now, when the goiter or when the thyroid gland goes through the thoracic inlet, they compress the trachea, they compress the esophagus, and they even compress the neck veins if they're large enough. And that's why some of these patients may come with dyspnea, endosphagia, and facial plethora. And I think this is something that's usually described in history and classic endocrinology books. And sometimes it even may compress some nerves and it causes hoarseness. Now, when these patients either flex or elevate their arms, then that thoracic inlet is sort of pulled up into that cervical goiter, and it acts as a little cork to the neck of a bottle. So that's when the Pemberton sign appears. And that's classically described as a congestion of the face. It produces cyanosis. And the patients are actually distressed when this happens. I think I've only seen this once in a very uncontrolled patient who came like from Haiti. I saw this in Boston. It's really rare, but it's interesting. Now, I have not added. I had another slide here, but that's perfectly okay that it's not showing up. I want to discuss pseudogoiters as well. So a thyroid gland may appear enlarged, even though it's normal in size. And you guys remember the rule of thumb. There are 3 different causes for this. The first one is you may have a high-lying thyroid gland. And actually, I'm going to try to do a new share. Okay, thank you. All right, so a high-lying thyroid gland, even though the thyroid itself is large, because it's so high in the neck, meaning that it's like this laryngeal prominence that we were discussing, the V, it's almost 10 centimeters or even further away from the suprasternal notch, then it looks like the thyroid is larger than it actually is. And this is actually relevant because it accounts up to like 8% of all referrals to endocrinology for goiters. You may have cervical masses in the neck. Think of adipose tissue, people with large necks. Cervical lymphadenopathy may look like a goiter. People with brachial cleft cyst, and we may see this in the younger patients in the early 20s. And it's important to know how to palpate and differentiate these lesions. And then we have something called the Modigliani syndrome, which is that normal size thyroid that is sort of in front of an exaggerated cervical spine lordosis. And it's actually named after an Italian painter, Amedeo Modigliani, who had a lot of portraits of people, for whatever reason, with enlarged necks. All right. Now, like I was saying before, and like Nadeem brilliantly explained last week in the 4th of the EBM sessions, the likelihood ratios are sort of a test or are sort of the way of us knowing if a patient with an expected whatever disorder or disease will have, or how do I explain this? It's a way to know that a result will be expected in a patient that has a disease compared to the likelihood that the same result will be seen in a patient that does not have the disease, if that makes sense. So it's something that we use to guide our clinical exam, diagnosis, and posterior treatment, right? You're trying to see with this ratio what the likelihood of an illness is in a particular patient. So the higher that ratio, the more likely they are to have the disease or the condition that you're studying. And vice versa. The lower the ratio, the less likely it is that your patient has a condition, right? You can use a rule of thumb, and I'm fortunate to have Rafa here to correct me if I'm wrong, but basically, if you have a likelihood ratio of 0 to 1, it kind of means that there's a decreased evidence for a disease. The closer you get to 0, the lower the likelihood of a condition being present. The more you get away from 1 or above 1, the more likely it is for you to have a certain disease. A likelihood ratio of 1 does not give you any sort of diagnostic value, okay? Oh, are there questions in the chat? Oh, no, it's Rafa. Thank you so much for sharing. So this is what we're going to be using to explore the thyroid pathology. Now, the first finding, let's say there's an absence of goiter by inspection. You're looking at your patient, you're palpating, you can't see or sense anything, then that immediately decreases the probability of there being any goiter of an enlarged thyroid. And this is what we see with the likelihood ratio of 0.4. An intermediate finding in this case would be, let's say I can palpate something, but I can't really see it when the neck is in a normal position, which kind of suggests that, you know, a subtle enlargement that you can palpate that you can't really confirm by just looking at your patient's neck does not really tell you that the patient has a goiter. You see, the likelihood ratio is not significant in this case. The probability is closer to 1. If you have a gland that you can palpate and it feels enlarged because it's greater than the patient's distal phalanx, and you can actually see it on inspection, look at the likelihood ratio of that patient having a goiter. It really shoots up the probability of that being present. Now, as we know, hypothyroidism is that clinical syndrome, the constellation of symptoms from having diminished levels of thyroid hormone. And this will decrease the patient's metabolic rate. It will slow their neuromuscular reactions. And it actually also increases an accumulation of mucopolysaccharides. And we'll see this later in the physical exam. Now, the usual causes for thyroid dysfunction or low thyroid hormones are going to be inherent to the gland itself, primary hypothyroidism, we call it. And in most cases, the most common condition will be Hashimoto's thyroiditis. As you can see here, 60 to 70% of cases, and or previous radioiodine treatment for Graves' disease, which is a lower percentage of cases. Now, the examination, like we said, is essential. Even though we know that you're ultimately going to make the diagnosis based on the lab tests, which has been around for hundreds of years, there's 2 reasons why you still need to examine your patient. So an examination, like we said, will estimate what the likelihood of thyroid disease is. So you can identify those subgroups of patients with either a high or a low probability of having the disease, and then compare this to the laboratory tests that you have and use that to increase the yield of your testing. The second reason why you need to examine your patients is you do have conditions like subclinical hyperthyroidism and SICU thyroid syndrome. Well, you're going to have an elevated TSH, you're going to have some laboratory abnormalities, but then your patients won't have any bedside findings of thyroid disease. Okay? As you can see here, in patients that have a suspected thyroid disease, there are certain findings that increase the probability of it having a low function. The first one is hypothyroid speech, and we'll talk about these later. Cool and dry skin, a slow pulse rate, and I'm not reading out the likelihood ratios, but you have them in the table next to you, and having delayed ankle reflexes, among other responses. Now, there are other findings that we learn about classically in our schools, like the hair loss in the eyebrows, finding like coolness and dryness is just sort of isolated, or patients come in and they're like, oh, I'm definitely hypothyroid. But the likelihood ratios for these findings are not significant. So that doesn't really help us in the diagnosis, right? There's no individual finding, whether you have it present or whether it's absent, that will decrease the probability of a patient being hypothyroid. What are these physical exam findings in a hypothyroid state? And I included this here, despite common belief, obesity is not more common in hypothyroid patients than in euthyroid patients. So this is something to share with our primary care peeps who want the TSH. Now, thyroid dermopathy, right? The skin is where we're going to be starting, is affected by the accumulation of mucopolysaccharides. And I put this here, hyaluronic acid, chondroitin sulfate are the 2 main molecules are just sort of accumulated, giving you that non-puffiness for that the skin. And these just sort of bind free water, and that's why the skin looks this way. The patients look, yellow. They have this tint because of hyperkeratinemia. They have a coolness of the skin, and this is mostly because you have a decreased thermal blood flow. They'll be dry because there's a decreased sebum production. And I remember when I was in medical school, the more senior attendings, they were huge. I was trained in a hospital in Spain. They were huge on seniology. And their pro tip was always to look at the patient's eyebrows, because that could tell you a lot whether they were hypothyroid or not. But actually, just looking at the evidence, when I was preparing this lecture a couple of years ago, this is a very non-specific finding. So even if you see it, it doesn't necessarily mean that your patient's hypothyroid. Now, hypothyroid speech, I mentioned it before, had the highest likelihood ratio is about 5.4. In a third of these patients with hypothyroidism will actually present with this, and that's a slow rate, sort of, deep, low-pitched hyponasal. It's like your patient has a very bad cold. And we think that's probably because there's some of that mucinous material that's also deposited in the vocal cords. When we discuss hyperthyroidism, that's just the opposite spectrum. You have a high metabolic rate, and then you will also find some very characteristic skin findings, neuromuscular system findings, and even eye involvement. The main causes of hyperthyroidism will be Graves' disease. You can see here up to 90% of cases, but you also have your toxic nodular goiters, you have the thyroiditis, and let's not forget, obviously, overtreatment with thyroid replacement. That's a big cause. And of course, it being a lot of autoimmune conditions, it will affect women more than men. Now, the findings that will increase the probability of a patient being hyperthyroid, as you can see here, are lid retraction with a likelihood ratio of like 33, lid lag, fine tremor. If we saw in the exam, it's important to take a look at that, having moist and warm skin, and having a fast heart rate, so more than 90 beats per minute. There are other things that will decrease in this case. This didn't happen for hypothyroidism. There are other things that will decrease the likelihood of a patient being hyperthyroid. So if your goiter is normal, most likely you're not hyperthyroid. Having a heart rate that's lower than 90 beats per minute, and not having that fine tremor will actually have a likelihood ratio of 0.3, which decreases the likelihood of your patient being hyperthyroid. So this, it's an easy thing to examine when you see your patients in the ED or the primary care. Now let's discuss those findings, right? Like we said, the goiter will be present in up to 93% of patients. And in some of them, we may find that we have a bruit. But we have to take this with a grain of salt, because in elderly patients, that could also be a carotid bruit. And maybe because your patient is hyperthyroid, not necessarily coming from the gland itself, but more from a cardiac output of hyperthyroidism that's sort of increased. You see here included some pictures of classic eye findings, which we have said in the slide before this, are the most likely going to increase your likelihood ratio of your patient being hyperthyroid. The first one, or the first classic eye finding, is the lid lag. Now, the lid lag is that appearance of the sclera between the margin of the upper eyelid and the corneal limbus as your patient is looking downward. So what it means is the cornea looks down, but the eyelid is not following. Lid retraction is different, and it will look different. The lid retraction is this widened palpebral fissure, and that's just like, see, like the patient's sort of staring at you. They look scared. It's very peculiar. And as the patient is looking straight forward, you can see that the upper eyelid is positioned abnormally high. So normally the upper margin of the, the lower margin of the upper eyelid would be sort of resting below the edge of the corneal limbus and kind of covering about 1 millimeter of your iris. And here you can see that because it's positioned abnormally high, you'll see, you know, there's a lot of sclera there. You shouldn't be seeing. The patient kind of looks startled. All right. This lint lag and the lid retraction are actually attributed to sympathetic hyperactivity of hyperthyroidism, which we will see again in the skin and in the neuromuscular system. Both of those are probably caused by the excessive contraction of the Mueller muscle, which, if we remember, is the involuntary lid retractor or lid elevator that, if it's affected, causes paralysis in the Horner syndrome. Now, these findings may actually be unilateral, and even if your patient is euthyroid, you may still have, you know, these eye findings, especially Graves' ophthalmopathy. In Graves' ophthalmopathy is a constellation of signs. Up to 50% of patients with Graves will have this condition, and it's mainly caused by all the edema and sort of the lymphocytic infiltration of that orbital fat, the connective tissue, and even the eye muscles. And characteristically, you'll see that there's a lot of edema. They have limitation to the eye movements. There's chemosis of the conjunctiva, and it looks injected, as you can see in the picture here. This is pretty representative, and also exophthalmos. So I remember my dad's an ophthalmologist, and he would always say, you can't really tell that there's exophthalmos from looking at a patient straightforward. You have to ask them to look up and just in a resting position, you'll see the exophthalmos, you see the proptosis of the eye. Now, the skin, like I said, in hyperthyroid patients, it's warm, but moist and smooth. And it's probably because, again, of this like increased sympathetic activity. So the sweat glands are hyperactive, and then you'll have that increased dermal blood flow. We have another finding here that we shouldn't be confusing with hypothyroidism, which is the pretibial myxedema. This is bilateral, and they're raised in firm plaques. They can be pink, they can be purple, they can be brown, and they're usually in the anterior chins, and it's one of the more specific findings of Graves' disease. We mentioned the fine tremor and just how high its likelihood ratio, and in assessing a patient with hyperthyroidism will become an important point. And of course, risk reflexes. When we're discussing hypothyroidism, one of the things that you may also find is a decreased ankle reflex. But that, you have to bear in mind, that may already be absent in some like older adults. And even in some of us, we don't necessarily have an ankle reflex. I'm checking on the time. We're gonna wrap this, and we may discuss diabetic foot, because I see that we have like at least 20 minutes. But I wanted to ask you if you have any questions about the physical exam in thyroid disease. Okay. So just briefly, the diabetic foot. It's really something that we see often, or we may miss often, unfortunately. 25% of all of these ulcers will actually result in amputations, so surgical removal of the bone, right? In the United States, I was looking this up, 5 per 1,000 people with diabetes will have amputations. So 2.5% of all diabetic patients will actually develop a foot ulcer. I don't see you guys anymore. Okay, Never mind. Some of the complications, occur because of diabetic polyneuropathy. Ulceration is one of them, charcoal arthropathy, and infection. Most of these ulcers will involve the forefoot, especially the toes, the plantar surface of the metatarsal heads. And this is just to know where we have to look at our patients. And although, neuropathy, ischemia, and infection will all contribute to the ulceration itself, the most important factor here will probably be neuropathy. So are we missing something, right? About half of patients that come with a diabetic ulcer will not complain of numbness whatsoever. They have no pain, and they can still sense a cotton wisp, or they can sense a pinprick. So maybe our examination is not necessarily sensitive enough to pick up on these patients. I wish I could see their faces, but I can't. Anyways. The Siemens-Weinstein monofilament test is the best way to identify which of our patients have a neuropathy, at least a sufficient neuropathy to put them at risk for an ulceration. So it's quite simple, right? Any foot is able to sense this kind of monofilament. That kind of patient will be protected from ulceration. The person who fails to sense the monofilament, that's the person that we need to be concerned about. And this is a very easy bedside maneuver, like I was saying. And the first thing that we need to test is the first and the fifth metatarsal heads, like we were just showing here. Now, to use the monofilament, the patient should be lying supine. You ask them to close their eyes. And the monofilament, and we sometimes do this wrong, it should be applied perpendicular to the skin with enough force to buckle the monofilament for about a second. And that's how you're examining this. And the patient will only need to tell you yes when they feel the monofilament. And you can check randomly both foots multiple times. This is just a summary of Charcot's arthropathy. It's a neuroarthropathy, and it's those, or it is referring to the neurodegenerative changes that will lead ultimately to a neuropathic joint and then ulceration. Most patients will come with a limp, or they'll tell you that they can't really put their shoes on. They've had some sort of swelling that they can't really explain. They may even have a fracture that they're not aware of. But they'll present like someone who just had a sprain, or someone that may have some sort of acute like arthritis or whatever. 100% of them will have pain and will be either like hyper-aesthetic, or they will have no pain at all. 60% of them will have bone deformities, and you can see some of the deformities seen in this image. And then like a lower number, only 17% will actually have that soft tissue swelling. If you see a callus formed, you have to test and make sure that you do this in all your diabetic patients. I'm not going to go into osteomyelitis, but the main thing is that it's important to know that there are the 3 different predictors of a wound not healing. And one of them is related to osteo and having a wound that's just like in full thickness and exposed area and whatnot. I'm going to stop again here.